Good afternoon, all folks, and I'm very happy to present to you what we can call the implant planning on AxisGuide. This is based on a huge experience that we have, not only by ourselves, but by our customers who are working with AxisGuide. And we know that they come back to us with the same questions all the time. How can I plan my implant in a proper way? I am too deep, or I'm not, I've not enough bone and all that. And this is the question we're going to go over. And it's not limited to one or two cases. I will present you about 11 cases, different cases. And I will start with the beginning of all that. And the beginning of all this is, Shad, I cannot move that, is this. So, first of all, last time I started with the Dicoms. What is a Dicom? How we get the image, what kind of image treatment we do, and all that was done in a previous webinar. If you did not attend this webinar, we can forward to you a link. You will have to ask to Arshad. He will send to you a link to know about all these things, which are really basic things that we need to understand. The second step today is implant planning. Of course, it's very important. It's important because the surgeon is responsible for the implant planning. Here at ANPA, we propose to you some implant planning, but you need to validate the implant planning. And implant planning might be different following your objectives about the restorative dentistry on implants, and about what you have and your skill in making more bone or not. So based on all this, the implant planning might be different on the same case. So you need to sign your implant planning because you are responsible for that. And the last step, this will be my next webinar. I will talk to you about the surgical guides. I invented the first surgical guide, which was called the SAFE system in 2000, 23 years ago. And today on the market, you have a lot of copies of that. But we started that with Materialize at that time. And since that time, I mean, there are very, very few enhancements. So I will talk to you in deep about what is the surgical guide, where we can have some mistakes based on the use of surgical guides and how this is working. Today, let's start with implant planning. Implant planning, we go to image from spiral CTs or CBCTs. There is a difference in between this and that, and I explained that to you last time. We can make some double scan in full cases. We can make optical scan coming from the Plastica scanners. We can make intraoral scanners, and we can go back from Axis files after image treatment. So I will not go in deep on that. You know all that. And we go to the next one. The next one is the AxisGuide Docs Assist, and we go to plan. This is where you are going to plan your implants. So it's very important to plan implants because planning implant in 3D will help you to understand what you can do and what you will find. Based on the quality of what you've been doing at the first step of the treatment of image, you will be able to decide if you need a bone grafting or no bone grafting. In this case, this patient had some baby teeth remaining here, and he went to two different implantologists, and both of them said to him, we need to make a bone grafting before we can place implants to you. And he asked me for bone grafting. I said, no, I don't do bone grafting. I'm going to study how much bone you have and how it's working. We did that, and we've been studying that it was not needed to add bone because we add enough bone. And the patient was very happy because we didn't need to make a bone grafting. So be careful before starting anything. Be sure that you take the right decision, taking the good analysis. What we can do also, we can have teeth where you have enough bone and the emergence is in good position, but in some cases you may do an immediate extraction and implant placement. So the decision is not to use wide implants or narrow implants. This is not a good question. The good question to ask is, how can I immediately stabilize this implant in this big void? Okay, it can be increasing the diameter, it can be increasing the length, it can be selecting some kind of special kind of wires to stabilize the implant. So this is what we need to study, and we can study that on the images. In some other cases, like at the bottom right here, I can place some implants, orthodontic implants, to modify the position of the teeth without wearing a big appliance outside of over the head of the patient and all that. We just put screws in the right position, and I will show you how we do this. Because if you do that, and if we work with some orthodontist close to you, it will be very helpful for them to do that. So let's go to the next step. Next step will be working on scanning appliance, because this will give you important details about what you can do. Without scanning appliance, you don't know where you are. So the question will be, do I need a scanning appliance before sending the patient to the CT scan? Or if I don't need to do it, I can send him directly to the CT scan. So we'll talk to you about that. This is the first step. We talked about the second step in the last webinar, and I'm going to work in deep on the implant planning. Step 4 and 5 will be done later. We have time for that. So how we can decide if we need a scanning appliance or not. A scanning appliance is a kind of a denture, which is radio opaque, and that you put in the patient's mouth before taking the CT scan. So I divided in three options. So you have few teeth removed, 1, 2, 3 teeth removed. You may have many teeth removed, 4, 5 or more teeth removed, and you have full cases. So let's start with few teeth removed. On this case, what you see, we have a teeth which has been removed here. The question is, do I need to send the patient to get an appliance, scanning appliance, before going to the CT scan? Of course, the answer is no, no need, because you have a tooth in front, you have a tooth at the back, you have the height, you have the position inside the bone, no need to have any appliance. So in this case, and you will encounter this kind of case with agenesis of the lateral incisors. So the patient has had an appliance like this, which was bonded at the back of the incisors and canine on both sides. And this, like usually it's happening, was falling down and down and down. So one day, this guy decided to have implants to replace the teeth. But this is a grown-up guy, 54 years old. We could not start again doing orthodontic treatment. This is too late. So we needed to find if we had enough place to do it. So to do that, okay, let me go back. Voila. To do that, do I need an appliance to be wear during the CT scan? The answer is no. We can know where we are. We have the adjacent teeth. We have the position of the teeth, and we will decide exactly where we want the implant to come. I will show you a real case on that. So on this case, on the lower left side, we have this tooth which is broken. You have an infection. We have this. We need to remove this and this. Do we need to have an appliance on that? The answer is no, because we know where the teeth are. we will change this premolar for a molar, and we will place 2 or 3 implants. We know exactly where to place them. So no need to have any appliance on that. In this case, lower left side and upper right side are different. On the lower left side, you have a teeth which is broken. You have a temporary bridge that you can manage to see on the CT scan. So we don't need anything. We have enough information, and we can plan implants to emerge exactly in the center of the teeth. So no need if you have a temporary bridge. And if you have barium sulfate inside, it's even better. So when you build up your temporary bridge and you are not sure if you want to make a bridge or if you want to make an implant, put some barium sulfate inside. By 10%, it's enough, and you will know exactly where it is and how you can manage that. On the upper right side, I need an appliance because the premolar and the molars are missing. I don't know exactly, due to the resorption of the bone on the upper, I don't know exactly where are the teeth. The teeth will be in accordance with the lower teeth, exactly on the opposite teeth in occlusion, and we need to know that. So to do that, we need to do a scanning appliance. The way we do the scanning appliance, I invented this system in 2000. And since that, we don't change anything. We make a wax-up at the lab. We include the occlusion, of course. With that wax-up, we make a plaster cast, and we fabricate this piece of thermoplastic plastic, which is covering the teeth and placing the teeth in the right position. And then we open. I opened that since 2000. We make openings instead of placing pieces of metal or titanium or whatever. So we now make openings, and we stabilize that like this. So I know now I have canine, premolar, molars. Yes, here I need to know where the teeth will be. So the scanning appliance will be done in this way. And if you want to do it, so excuse me, I cannot go to the next. Yes. And now let's go to the full case. So partial cases with few teeth or no teeth, no need to use a scanning appliance. In most cases, you will never need to use a scanning appliance. For most advanced cases where 4, 5, 6, 7 teeth missing, then it's good to make a scanning appliance to know exactly where you're going to finish your case with the emergence of the implants. And now we go to the full cases. So full cases, it seems that it's a little complicated for most of the dentists who don't understand exactly, and the radiologists, how to do a double scan and how to make a full scanning appliance. I am going to explain that to you because it's important to know how to do. The first thing is full scanning. On full scanning appliance, on full upper, for example, here, we have a denture, and we are going to set up the teeth in this way with a wax up, with teeth to set up that. I started like this in 2000, and I opened the opening like this, and I advise you to do the same because this will give me the exact point where I want my implant to exit. So doing that, you will have the image of the teeth you want to replace. You will have the point where you want that implant to emerge. And this is and was at that time radio transparent, and we've been changing that for different things now. So I changed that, and I made a full denture, and a copy of the full denture was done. And this is coming from the existing denture, and we make a full scanning appliance. How this is done? It's done like this. You have the teeth in one color. You have the base plate, and the base plate is pink because in some cases I will use this as the immediately loaded temporary bridge on implant immediately after placing implants. And I can do that in one session because you have all the information which are available on this scanning appliance. So you see that you have the small barium sulfate powder inside. This is the upper, and this is the way we distribute the value. 30% by weight of barium sulfate compared to the acrylic. The acrylic powder, 30% zircon, barium sulfate, and 10% for the base. There is what we call a gradient. What is a gradient? Is a big difference in between the 10% and the 30%. I have been testing from 5 to 60% every 5%. And finally, I have been falling on that value, which is 10 and 30% by weight of barium sulfate. So based on this, we know how to do, and we are going to work on that. And this is the way we do. Based on this, we can have this kind of image. And this, we started that in 2001, and I published that in 2002. So you have a mask, which is a group of pixels of the teeth, and I am interested in getting this mask to see the emergence of my implant. On each implant, we have a prolongation. I will explain to you why we have this presentation and what is the length of it in the next slides. So we should emerge in the center of the teeth as much as we can do. In some cases, we cannot do that, and we will see how we can manage that. And we have the base plate. Why we have the base plate? Based on the previous picture I showed to you, we had a transparent base plate. But we started in 2001 working on a transmucosal full treatment, like on a full upper. I will not open a flap. I will just place the guide on the soft tissue, and I will guide my implants with the guided surgery. Guided surgery, I will talk next time, but I needed more information about the soft tissue and how do I get that on a CT scan with the scanning appliance or the denture of the patients. The internal surface of the denture is the surface of the palatal surface. So doing that, we've been able to find a way, because before we could not do it. So when I tell you 20 years ago we did that and that, is that before we could not do it because we had no solution. So we've been finding two solutions to work with this, and until today, this is valid. There is no issue on that. And then we have another mask, which is the mask of the bone. Okay, so based on all these masks, I can manage my case, and I have been doing in that case a case where you have 4 anterior implants, 2 Zygoma implants, and 2 implants on the pterygoid wings. I am going to explain to you how to draw a Zygoma implant and how to draw an implant in the pterygoid wings, and I will explain also to you how to plan implant in the anterior. So you will know how to do this kind of case, and this kind of case is very interesting because due to all these implants, we can immediately load, and the patient is very happy to have his implant so fast. I'm not talking about a new way to make an immediately loaded bridge. I'm talking about what we used to do 20 years ago, and still today it is fully valid. So this is explained in the Art of Computer Implantology book that we published with Alan Rosenfeld a long time ago, and which is always valid today. So we've been seeing on full cases how we can manage with full scanning appliance. You know now how to build a full scanning appliance, and you know what this scanning appliance will give to you. But if we have a good denture, with a good support, which is not moving, and good teeth, then we can go to the double scan procedure. This is a double scan procedure. It has been explained by Benoit Philippe and Laurent Serre in a very interesting article. And double scan means what? You take a first scan with the denture of the patient in his mouth, separate from the opposite arch, biting on cotton rolls. Don't ask the patient to bite teeth against teeth. We can, because we will not be able to know what is the surface of the teeth and the architecture of the surface. So we need to separate the upper and the lower. We put the patient, and putting the cotton rolls, we will be able to fully put the denture in the right position. Okay, it's like when a patient is biting on articulating paper. You ask them to bite at the level of the first molar and premolar. And then we take a second CT scan, and this is the second CT scan of the denture itself. And you see you have some good aperture point here, 1, 2, 3, 4, 5, 5 or 6, it's enough. So to avoid the good aperture falling down like this, what I do, I'll make a small 2 millimeter deep hole, and I ask my assistant to make small beads of 1 or 2 millimeters, and I put the beads inside of good aperture, and this is much more stable than how it has been shown here. So then we go to the next step. We have 2 scanners, and when I build up the AxisGuide program, I have to have a Dicom registration. So in Dicom registration means that you have the Dicom, you have the CT scan of the patient wearing his denture, and you have another CT scan, another Dicom of the denture itself. And automatically, you will get the denture of the Dicom, and you will get the Dicom, and one will be going over the other one. And this is fully automatic. You have nothing to do. The program will find out where are the common points on both of the Dicoms, and will draw this. Doing that, you will have the information about the surface of the gum. You will have the information about the teeth. And if you want, we can even separate the teeth from the support. And this will be easy for you to manipulate the image and do same as you were doing with the full scanner guide I've been showing to you before. But in some cases, you have this. This is the image of the denture. This is the image of the bone. This is the image of the soft tissue. And you see there is a black hole in between this and this. This means what? You have it here also. You have it here also. This means that the patient did not bite in a good way when we've been placing the denture in his mouth. And this gap, we cannot fix it. So when you will get your surgical guide, the surgical guide will not stay in the right position. So be very careful about that. First of all, if the denture is not stable, you need to realign the denture. And if the denture is in position, make sure that the position is stable and that the patient is biting on the cotton rolls in a good way. If you don't do that, you will have bad surprises at the time you're going to place the implant. And this is a big risk of mistake. So I have all these cases to show to you. I will close the first part, which is about the scanning appliance and what you get, kind of information you get from that. And now I am going to go and explain to you how we can plan and what kind of tools we have in a case which is called Caesar. And I'm going to explain that to you. So I go here, I go here, and this is Caesar. Okay, so Caesar is a case where I have to plan one implant. So to do that, I need to show you how you can select an implant first. So I go here. So the first thing you can do here is you can give a name of your implant. In my case, it's 46, and you can do all that, okay? You have the FDI or the US numbering system, which is this. What you have here is that these are the 10 last brand which have been used for this number 46. And you have the reference. So no need to go in the full list of implants. You already have in that. So most of the time, I use a diameter which will be maybe 4.2 or 5. And this will be here in the system. You don't have to do that, okay? Automatically, you will have your bait choice coming from this. This is for 44, 45, and you have the same system which is coming here and showing to you which kind of implants. So instead of 4.2 or 5, you will get 3.3 in some cases here, based on the quality of the bone we have, okay? So, and then you can click on that. And when you click on that, automatically here, you will see your implant design, which is rotating, and you will know what kind of implants you are talking about. Because in between the MS, let's say MS 3475 and the Master C 4.510, you see there is a big difference. And knowing that there is a big difference, you will know what kind of implants you are going to place. Soft bone, limited amount of bone, very deep and strong bone. So all that will allow you to select it because you will see it immediately. So not only you have the standard implants with Antogir, Bicom, Triple I, Straumann, and all these implants brand, but you have also some retention screws. So retention screws is important. So you have this kind of retention screw. Retention screw can allow you to stabilize the guide in the bone, okay? But not only we have this, we have also pins that you can put through the guide inside the bone to stabilize the guide. So, and this, you will be able to find it in retention screws, osteosynthesis screw. So you have southern implants, okay? So you have some kind of extra roll implants, very, very short implants. You have, I show you all what you have, all these implants also from southern. You have the orthodontic implants. I will show you why I like these orthodontic implants. So these orthodontic implants, let me go back. I show you again, orthodontics implants. So here is the orthodontic implants I like to use. Why? Because they are a screwdriver, you can screw them on top, and there is a hole here, okay? So you can put a wire and attach it very easy way. You can screw them in an easy way, and you have this gauge here, okay? And you can put an elastic also. So this is the design I'm looking for orthodontic implants, okay? So let's go to special implants, okay? In special implants, we have Shatkin's implants, so very short implants. You put a lot of short implants in this case. So these implants are including the abutment. They are used mainly in US, and you have southern implants, and you have oncology and Zygoma implants. And I'm going to show you some Zygoma implants, long implants, 45 degrees and all that. And I will show you also what you can do with that. So you have these special implants, orthodontic implants, and you can, if you don't have your implants, you can draw them. And we call that the generic implants. So you can decide what is the diameter of your implant. You can decide what's the length of your implant. So you have absolutely no limitation in using any kind of implants you can find on the market. Okay, so knowing that, you will know what kind of implant you will be able to use for, let's say, 46. And then you go to this implant, and you can modify. I like a stronger one, and I like this one, and I will validate. When I validate, I can go here and I can place my implant. So I'm going to remove the other one, and I have the good one. So how can we do now? And look at that, because this is special in AccuDent. So the first thing you see on top of that is the prolongation of the implant. The prolongation is 15 millimeters. Why? Because in some cases, the implants are so in different axes that you may have some difficulties to place the pickup impression copings, which are 15 millimeters, and they will touch each other. Knowing that, I designed that prolongation at 15 millimeters, so I am sure that when I'm going to plan my implants, I will have no issue at the time I will take the impression. The second thing that you see is that the implant, the arrow, when I go here, I can rotate from the bottom. The arrow at the bottom, I can rotate from the top. Okay. When I go in the middle, I can position that in a good position. And then one thing more, when I am at the bottom, I can increase the length, or I can decrease the length of the implant. And also what I can do, I can change the diameter of the implant. I can make it shorter, I can make it longer. And you see that the color is changing. The color is changing because I decided to use the international coloring system that you have in endodontics. It is white, and then it changes for yellow, blue, and dark. Okay? So based on your system, you will know immediately what's the difference of what you have. One thing more, if you don't have a tooth to guide you where to emerge, look at that. In this, you have a space here, which is a dark space. This is the couloir de château. This is the corridor of château. The guy who has been naming that, saying that in this space, it's in the middle of the force going inside and the force pushing outside. And this is where the teeth are going to stay. So when you are lost, you don't know where to plan your implant, you plan it in the middle of this space. Okay? When you go too deep, too fast, the color is changing. When you are too close, like 2 millimeters, too close to the nerve, the color is changing. It is just to show you that you are less than 2 millimeters. Is it dangerous? Maybe, if you don't use a guide to place your implant. Is it dangerous if you use a surgical guide? Not at all, because we find out that we were never going deeper than the depth we had planned on the planner before doing the surgical guide. So no error will be possible using a surgical guide when you are close to the nerve. And this allows me to place implant very close to the nerve, like a millimeter or half a millimeter, because I trust in my system, and this has been shown many times. So you know how to manipulate an implant. When the manipulation is done in 2D, we go to the 3D. So on the 3D, you have this. This is the tooth which has been added. Okay, you can add the tooth. I remind you that from last time. So you can take a copy of this one and make a copy to go on the other side, or make a wax, a virtual wax to replace the tooth. And now I am going to slightly move my implant because I want my implant to emerge exactly where I want it to emerge. So it is there. I can remove the wax up. I can see the emergence of my implant. I can make it higher. I can make it deeper. This is great for people working on Straumann system, on a soft tissue or a bone level. And this will allow you to decide where you want to place your implants. Okay? And doing that, we will be able to guide it to emerge in the exact right position. I have been working years ago on a program which was a robot automatically making the planning instead of you making the planning. This program was called Dr. James. So I have a long lecture on Dr. James, because before asking the programmers to design this tooth, I needed to know how I was placing my implants. And in fact, there are two ways to place implant. The first way is to place implant in the middle and inside of the bone. And the second way is to place implant emerging in the middle of the teeth. When you have big bone and when you have big tooth, it is possible to do it. This is the pure example that we can do it easily. So we have big bone, we have big tooth, it's possible to do it. But in some cases, and almost on the upper anterior, there is a resorption, and the resorption will not allow you to place implants to emerge in the cingulum of the teeth. And in this case, you will have to use angle abutments. And I don't like to use angle abutments. I like to have my teeth which are screw retained. And I don't talk to you about few cases of implant. I've been placing more than 25,000 implants, and I have all the bad issue that can happen. And some of the bad issue happened when I had a screw retain abutment and a cemental retain crown on top of the abutment. And in these cases, in some cases, the screw is unscrewing, and then the tooth is moving, but you cannot separate the tooth because it's cemented too strongly. Okay, so for this reason, I rather like to have my implants to be screw retained, my teeth to be screw retained directly on top of the implant, easy to retrieve and very quiet thing. Okay, so you know how how to plan this implant. I am going to go a step further with you. I am going to remove that, and let's say that I want to place an orthodontic implant in between these two teeth. Okay, an orthodontic implant will be placed perpendicular to the bone, on which you will be able to attach some elastic, and this will allow impacting the tooth inside. We do that on the upper most of the time. I just want to show you here to allow you to understand how we do that. So I want to go here in between these teeth, and I want to place an implant which will be almost horizontal. So I go to plus, I go to select my favorite implant. So I go to retention screws, orthodontic screws, easy implant screws, and I'm going to take one implant which will be like this, which will be 8 millimeters. I validate, and now I place my implant. First of all, the implant will be placed vertically, and then I'm going to orient it horizontally. I'm going to put it in between this and this, okay? And I'm going to change the angulation, and I'm going to put it inside, in between the roots, okay? So very easy. I put it down a little, I put it up a little, and this will allow me to stabilize the elastic coming all over. Let me put back the bone now. I put back the bone, and I see that my implant is a little too short. So if it's a little too short, I can click on that. I can open it, and I can make a longer one. 8 millimeters is too short. I do to 10, and I validate. And like this, I can put it a little more outside, okay? And in the soft tissue, it will emerge like this. And if I remove the bone to show you again, I see that my implant will not interfere with the adjacent root. And this is exactly what I want, and I can control that. And the orthodontist I'm working with is very happy with that, because he will save a lot of time to impact these teeth. Okay, so I think I have been covering the the initial things that we can see with that. And I am going to show you another case. So on which case we are now, let's go step by step. We have seen the planning, okay? Let's go to an orthodontic case. This is a case I did in 2012, and I'm not going to show you all the case from A to Z because I just want to focus on the planning today. So this was the patient. So she had a very big gap from the anterior upper and lower teeth. And the orthodontist asked me to plan orthodontic screws. So he did not say me where and when. And I planned on both sides, buccal and palatal. And this is the plan. And this is the plan on a different view, another view. And this is the way it is working. So here, you see how it's working. And this is a dolphin movie. They place implant and they place an elastic. This is the elastic, and they pull up the tooth in this way. Voila. Okay. So what they don't say is how they guide the implant. And me, I show you, I don't know if you can see that, but this is the guide I have been using. And you have the holes inside for 2 millimeter diameter, and the rest is placed. And doing that, I can do this. And this is the day of the surgery. I have my 2 implants. Once again, I like the hole in the middle. In some cases, I place implants much higher in the Zygoma eminence. And as long as there is much more soft tissue, I need to use long wires to get access and to go to elevate the teeth. So I do this, and I have my 2 implants same day, on the day of the surgery, no bleeding, and we don't need to wait for osseointegration in this case. And immediately the orthodontist can start working on that and can start applying the elastics. So is placing elastics. Is placing elastics. And some days after, I had to remove the first premolars to allow him to put that back. And you see that all that is very close now. So this means that we've been able to impact the molars, the upper right and left molars. Okay, so this is a case. I want to show you another case. I have been starting, so I go on, done in 2013. So this patient, as I explained to you, we didn't need any scanning appliance, and this is the case. And we've been planning implants. You see that it's very, very narrow. So the implants are conical, and the top is 3.3 millimeters. So I don't want to touch the adjacent roots because this might be a cause of failure. So I do like this. So you see how close it is. So it is difficult to do it manually. And we have a resorption on the outside. This is the design of the guide. This is the reference. I will talk to you about all that in deep in my next webinar. And this is the case. So I open a flap because I want to control what I'm doing, because it needs to be very, very accurate. If there is any mistake in that, okay, I am wrong and I touch the teeth. So I drill like this, I get the opening. So I have been planning. So we talk about the planning. You see the bone is like this. It's concave instead of being concave, okay? So as long as we've been losing there, we cannot put the hole here. It will be too much outside and the metal will show, or we will not have enough connective tissue on the buccal side. So because of that, I change from the middle, I go more palatally. And this is what I ask you to do when you are planning implant. It's a little or more resolved bone on the upper, go palatally and try to emerge at the level and the high level on the buccal, but start palatally. And this is what I did here. I start palatally and I go after with another kind of guiding system, which is an easy system with a sleeve. And I check the final positioning of my implant. I want my implant to be at the level of the bone, so I make it a little deeper, okay, little deeper, and then I can close. I put the cover screw. You see, I'm exactly long axis. Do I touch or not? Okay, so I have to take the X-rays for that, and I have to check. You see, it's deeper now, and it's okay for me in the exact position. I close and look at that. So you see, there is no space, no space. Okay, it's very accurate. And this is what I want to have. I want to be able to do things which I'm not able to do using my fingers or my brain. I want to be guided. Okay, so this is 2 implants on lateral. Let's go now to next step. 1 implant with an impacted canine. Okay, so this might happen to you from time to time. We have this kind of case. It's the impacted canine. So I open the case and I show the case to you. I have this case. So you know, here you have an impacted canine, which is in the palatal place. Okay, so when you take an OPG, you don't know where it is. So take a CT scan. This is the only way to know exactly where is your canine. So of course you can remove the canine, make the bone grafting, and place an implant. But you know, it's a big surgery, and in some cases it's not needed to do it because the canine position is stable. The challenge is to say, okay, I have a canine here. Can I place an implant here to replace the missing baby tooth, which is going to fall? And this is not a matter of 10 millimeters. It's very, very limited and very accurate. So you see, based on what I explained to you last time, we've been able to make a mask of the teeth, a mask of the baby tooth, a mask of the bone, and a mask of the impacted canine. And now I see where is my impacted canine, and I can evaluate the bone I have here after extraction of the tooth, and this is exactly what I'm going to do. So I keep back my bone. I have the canine which is emerging here, but I don't want to remove it. But I want to remove this baby tooth. So I remove it, and this is where I am going to plan my implant. I've been planning an implant. This is the implant. And I need to put it always, as I said to you, a little lingually placed. Okay, I need to check if it's touching the canine. I need to check the axis, and I need to check where it's emerging. So I put back the baby tooth, and the baby tooth is there. So I am emerging in the cingulum of this tooth. So I will be able to go to a screw retained lateral canine. A screw retained canine is very good for me. This is exactly what I want. I remove the bone, and then I see that I am not touching the canine. I am emerging in the right position, and I am in the good position. If I want to change it a little, I can slightly change it. If I want to make it a little higher for security, I can change it a little, and then I can go to my final, and I will get the guide to place the implant without opening a flap in the exact right position. Okay, so once again, you know now how to do that. I mean, it's very simple when you know, and I have been making a lot of cases like this, and it's working very well. Okay, so don't try to place an implant if you have no space. If you have no space, of course, you need to remove the canine. But if you are limited like this, yes, you can do it, and the prognosis will be very good. Okay, so let me go back. So now you've seen this case. I want to show you another case, which is a full case with bone reduction. Full case with bone reduction. This is not my case. It's from with the agreement of Dr. Joji, and I'm going to show that to you at the level of the planning. So let's go to the planning. Let's open the new case. We wait for the case, and here is the case. So what do we have here? What do we have? We have, I'm going to do this to make it more clear for you. You have some teeth here, which have hopeless teeth. They are moving, they are falling down, periodontal disease, a big infection inside the bone. And we want at the same time, this dentist wanted at the same time to remove all these roots and place implants. Okay. And this case was a very good success, but I'm going to tell you why the planning is very important. So we can remove the teeth, and we see that we cannot place implant like this. So we need to have a bone reduction. So we've been making a bone reduction, and this is once the bone has been reduced. Okay, so all the top was removed, and now the implant can be placed. It's flat, it's horizontal, it's clean, and you can place a guide on that. And with the guide, you can place the implant in a very easy way. How to place the implant? So now I show you how to place the implant. So we've been planning all these implants, and in this case, we have vertical implants and vertical retention screws for this dentist, not horizontal, but vertical retention screws. And all these implants have been placed. They have been loaded, Arshad, and they have been loaded immediately also. So you understand that when you plan, not only you plan the position of the implant, but you plan the new level of the bone. And not only you will use one guide, but you will use two guides. One guide to place implant and one guide to make the reduction of the bone. Okay, so this is a typical case that we find very often in the lower arch. What you see here, it's not a mistake. The implant is deep because we know that we will lose some bone after such a surgery. We will lose some more bone. So we anticipate the loss of bone and we play in security. If we remove that, we see that the implants are placed in a good way. No implant is touching the nerve. Okay, so we can reduce, we can place them a little higher, but we have a full confidence in our guides. And when we have implants 2 millimeters far away from the bone, from the nerve, we are sure that we will not touch the nerve. Okay, so this is one case I wanted to show you for the bone reduction, and for the retention. Let's go to another kind of case. Like pterygoid implants. So now I go to pterygoid implants. I have been using a lot of pterygoid implants, and pterygoid implants can be very useful. So I'm going to show you this and the way to plan pterygoid implants. So in this case, we have implants on both sides. The implants have been planned, and the implant I want to put here is in between the pterygoid veins the maxillar bone, and the tuberosity of this bone in between. You have three kinds of bone here. These, there is no risk. There is no big arteries, nothing. There is just muscles, okay? So when you place implants, they are very strong. And the prognosis is very good to place implants at this level. Be careful not to come too much inside the sinus, okay? So you will be, if you are too vertical, you go inside the sinus and there is no retention here. If too low, you will go here. It will be too much horizontal. So you need to be in between. And doing that, you are at this level. And the first is that you plan your implant somewhere like this here, okay? You try to place it inside the bone, okay? This is not a typical case. It's just to show you. And you go in a different way here, and you see that the bone should be always inside that. So I'm inside the bone here, inside the bone, inside the bone. So all the way I am inside the bone. Okay, so this is very stable, and this is where to find them. So when you want an immediate loading phase, on the upper right position, it's a little tricky. The implants are aligned. You don't have a triangle. So as long as you need to check that it's inside the bone, you need to check, and even if it's going a little more outside, inside the pterygoid wing, there is no risk. As I told you, there is only muscles there, and there is no risk to go a little inside the pterygoid wing. So if this happens, I will show you what happens then. I'm here, and voila, and it's coming inside here, okay? Instead of emerging in the middle, if this happens, it's not a big deal, but I like to make it emerge here in between, because you have a big amount of bone that you can use here, okay? So this is how you can take care of that. And when you do the prolongation here, okay, the prolongation will be in metal or covered by a ceramic if you want, but you don't need to make a tooth here. You can stop the tooth at the level of number 16 or 17 or whatever. So you can stabilize your prosthesis without making crown on that. Voila, this is what I wanted to talk to you about the pterygoid implant. Let's go back to the next step. Next step is one mandibular implant. Let me go there. One mandibular implant and the anatomy. This is something I want to talk to you about again. It's about the anatomy on the lower. So I take another case. Cruz. It's not Cruz. Excuse me, I made a mistake. Okay, this is good. Okay, what you see here, we have been adding an implant at the level of 47. So what you have to know is that these implants are special implants for two reasons. The more you go at the back, the more you will be close with the angulation of the nerve. So you need to be careful when you have a dental space going at the nerve. Okay, so you think always about the nerve here, but there is the nerve proximity here also. So be careful here. And the second point is that, I want to show you that very clearly, is that you have like a balcony. You see that? This is a balcony, okay? The bone is not deep like this all over. It's a balcony. So the implant should be inside this balcony. And in most cases, as long as this is coming inside, you cannot place your implant too much here. You have to place it more outside, not for the high level, but for the lower level. And I show you that in this direction here. And that this is almost everywhere the same. So you have that. When you place your implant, it is in the balcony. You see the implant in the balcony. In the balcony, it's here. It should, because of that, you cannot make it longer. Because if you make it longer here, okay, it will emerge outside. And emerging outside, your implant may touch the nerve, which is the lingual nerve, okay? So in some cases, it's average like this. It's not that much on this case, but in some other cases, it's really deep, deep like this. And when you plan your implant, you will have to plan it more outside, because more outside, you will fall inside the bone. And more inside, you will fall outside of the bone. So be careful when you are managing the position. In some cases, you cannot do it. In some cases, you will have to change the angulation, modifying the angulation of your implant. You will emerge like this lingually, and these will need to be fixed in the prosthesis if you want to stay inside the bone. But most of the case, you will be able to find a solution, even if you have shorter implant. And what you will see also is that if you take a panoramic X-ray, most of the time, you will see that these implants are short. They are not short. They are going to the bottom of the bone. And this is what you need to expect in most cases where this balcony is important. You need to stabilize with a shorter implant because you don't want to go outside of the bone. This is what I wanted to show you on the lateral sides. Let's go down to one more case. One more case is upper placing implants in sinus lift. Okay, so I show you that because I made a mistake and I wanted to show you my mistake. No, that's not my mistake. My mistake will come later. In this case, I want to tell you something. I want to tell you something. In most cases on the upper, I make a scanner before doing a sinus lift. And then I make a second scanner after doing a sinus lift, because by experience, sinus lifts are not 100% stable. You may lose some at the in front or at the back, or it can be a little porous, or you don't have 100% result in sinus lift. And knowing that, I make two. But in some cases, like in this case, I made two sinus lift, one here and one here is dense, it's clean, and you see that there is no issue. And on the other side, it's exactly the same. So as long as this and this are well done, I don't need to take a second CT scan. And the patient is happy for that because they spend no money for the CT scan, for the conversions, for all that. So I said to him, no, I can see that both sinus lifts are good. No need to take another CT scan. We can go like this. And this is what we did. We took the first CT scan. And we have been working on this first CT scan to make the case, to make the guide, and to work minimally invasive. So I have been planning implants, but you see my implants are planned in the sinus, but I know that there is no sinus here. There is a bone grafting, which has been taken very well. So based on this, again, I can plan my implants. My implants are planned exactly in the center of the teeth on both sides, right side, left side. I'm guided, and in 20 minutes, I can place my implants minimally invasive with a high level of security and accuracy. And in this case, I did not even need to ask the patient to take another CT scan. So I wanted to show that for you. So let's talk about this. These are the Zygoma guide. So the Zygoma guide, I need to show you something about the Zygoma. The Zygoma guide, I started doing the Zygoma guide in 23 years ago. So once again, it's not new. And I'm going to show that to you. So the Zygoma guide, and Luc Vreeling has been teaching me how to do the Zygoma guide. And this was at my clinic in France, where I was making a demo on Zygoma guide. So on the anterior, I placed 4 implants with normal guides. And we have special design for the Zygoma guide and the Pterygoid. In this case, you have a guide for the Pterygoid and a guide for the Zygoma guide. So you have 4 anterior. I will finish the case. I know I am a little more than 1 hour, but I want to finish the case with you. So we drilled there. We stabilized the guide. We are working in transmucosal. We did not open a flap. We are not laying on the bone. And this is the special handpiece I have and drill to drill the Zygoma. So I'm angulated, and I'm going to show you how at that time, 20 years ago, we used to fill. So now we stabilize the guide, and we have a marker asking us at what depth we are. So I'm drilling through the mucosa. I am drilling then through the palatal bone, and then I am empty. I am in the sinus, and my finger, or my right finger, is going to move, and it's going to move to the Zygoma eminence, and I'm going to feel the drill in the Zygoma eminence. You see where I am now? I am on the Zygoma eminence. I touch the Zygoma eminence, and I know where I am drilling. And in the Zygoma eminence, we need to stabilize by 3 to 4 millimeters. I explained that to you for the planning. How do you need to plan that? Okay, so you need to plan 4 to 3 millimeters, and then we do the same on the other side, exactly the same process, the same surgical guide, the same stabilized guide, and I go inside the sinus. It's empty now, and now I go and I feel the Zygoma eminence and the drilling inside the Zygoma eminence. So this is the, voila, here, I place it, and this is in real time. We did not cut anything, it's in real time. So the implants now, at that time, they were placed inside the sinus, but in some cases, we can also cut the outside wall of the sinus, push it inside, and push it inside, make a bone grafting, and then make the rest. So this is the end of the surgery, and this is the way it has been done. After we take an impression, the day after, we place the bridge. So this is what I wanted to show you. We take impression. So we've been planning all that. This is the plan. The Zygoma eminence on right and left side, the Pterygoid implants, the implants. Okay, so these implants were Nobel Biocare implants at that time. And we strongly tight. This is the implant holder. So you have a big handle and you tight, and you make all the small screws parallel one to each other. These screws that you see, and then we will be able to take the impression with all these implants emergence parallel. You see the screw, and this is the screw which will give me the orientation of the implants. So this is done. Anterior implants are done. I put some abutments, conical abutments, take the impression, and the day after, we just prepare the bridge during the night, and the day after, the patient comes, and we are going to screw retain the bridge. So this is screw retain on conical abutments. You see the conical abutments? The two pterygoid implants at the back with no teeth on top, and I screw retain the bridge, and I check the occlusion. And at the first bite, we know that it is perfectly adapted. Okay, so once again, this is the way to work on the Zygoma implants, and avoiding sinus lift, avoiding big bone grafting, and allowing treating patient in a good way. So next case, and I have only two more. It's one implant at the mandible. Okay, one implant at the mandible. I am going to show that to you. I'm going to show that to you. Excuse me. One implant at the mandible. Let me come here and select the next case. Ali. And after I have one more and I finish. So in this case, so it is the patient had already some implants in front. So I'm going to add this one. He wanted to add two teeth. He had these are implants and a bridge on top of that. So so he wanted to add two teeth. So the issue is that you see the implants in front and the bone. The problem is to go in between this implant and this bone. So once again, planning implant is a key to success. Okay, you cannot place an implant vertically here. We are too close to the nerve. You cannot place an implant vertically here because there is one already. So we need to go here in between. So doing that, we've been planning an implant like this. You see, very accurate conical narrow implant 3.3. Okay, master C. Okay, so you should not make a mistake. So once again, we trust in our system. We can place the implant in this way. We can slightly modify that to come in the middle. And this case has been done very successfully. And the implants are replaced without any issue in one shot in a very good way. So even in difficult cases, you can manage placing implant. But be careful. In some cases, if you want to place implants in an impossible position, okay, you will not be able to place it in real. So you can place it on the computer, but this is not what you want. What you want to place it in bone. So never forget that you are working inside the bone. The bone was very dense. The implant has been placed in very good position in a very easy way. I show you my last case now. This last case is interesting because it is talking about immediate loading, immediate placement. So more and more dentists, they want to go fast. They want to remove the teeth, place implant, and the patients, they like that. They want to go fast. So how we're going to do that? So we have two teeth to place here, and this is a normal case. You know how to solve that. So I will not talk about that. I will talk about the other side. On the other side, what you have is this. You have a tooth that we will keep for now. You have this tooth, which is hopeless, we need to remove. And this tooth we need to remove also, this root. So we are going to remove that and check if we can immediately load implants. So I have been planning implants here and there. And after planning, it gives this. You have the implants here. So I can show you that by transparency. And you see that my implants, once again, immediate placement, my implants are longer than the existing root. And here you have two roots, and my implants is staying in the middle of the two roots, and is longer than that. And both implants will be stable because they are implemented in healthy bone. So if I remove these two teeth, I have my planning here in the emergence and the emergence profile. I will lose some bone, so my implants are a little deeper than the crest of the bone. And because of that, I know that I will successfully implement these two implants in one shot and successfully place the implant on the other side in the same way, but without extraction. So this will be done minimally invasive. Okay, I will make them deep so that the soft tissue will cover again. And if I want to find the implants, I will use the same surgical guide. And if I want to increase the level of the soft tissue, I can make a graft, or I can make a laterally positioned flap to place more fibers on the outside of the emergence of the implant. And this was my last case. And I wanted to show all that to you excuse me. I wanted to show all that to you to show you different options in managing our case. So narrow case, narrow bone, big bone, pterygoid implants, Zygoma implants, immediately loading implants, immediate placement. This is a variety of situations that we will have to find. And I've been showing to you what could happen in case of mistakes and the way to avoid them. So finally, I want to tell you this, is that failing to plan is planning to fail. Okay, it's not from me. I've been hearing that since a long time in New York University. Planning is key to success. So planning implants in computer-guided implantology is key to success. Never, ever forget that. Voilà. I thank you for your attention. I've been a little long, but I think this was important for you to know about computer-guided implantology and planning. Thank you.